Welcome to this explainer. Today we're doing a structural review of Ohio's operational execution of the CMS Rural Health Transformation Program. We're going to bypass the general CMS background and focus squarely on program implementation, specifically how Ohio differentiates its approach under the federal statutory requirements. We'll be analyzing the state-generated project narratives, budget documents, and the CMS authoritative guidelines. So let's look at exactly how the state maps its program creation against those federal interests.
We'll be moving through 5 main areas today: CMS alignment and state baseline, clinical infrastructure hubs, specialized care and tech pilots, workforce pipeline execution, and finally, budgetary and administrative guardrails.
Starting with Section 1, CMS alignment and state baseline.
Drawing from the CMS 50-state spotlight and Ohio's project narrative, the state's target baseline covers 4.4 million rural residents spread across 73 non-urban counties. The state's documentation makes it clear that these specific regions are facing some very distinct challenges, namely strained healthcare infrastructure and significant provider shortages. This 73-county footprint forms the operational boundary for the entire funding rollout we're looking at today.
Now, let's look at how the state translates federal directives into localized action. The CMS program has a broad strategic goal to make rural America healthy again. Ohio, however, differentiates its implementation by setting very specific, measurable clinical targets through its Healthier Ohio Chronic Disease Track 1 initiative. So rather than just a generalized health campaign, Ohio's mandate requires participating subrecipients to actively reduce patient A1C levels by 10% and properly manage systolic blood pressure for patients diagnosed with hypertension. The federal goal is broad, but the state execution is strictly metric-driven.
Moving on to Section 2, Clinical Infrastructure Hubs.
The core operational mechanism of Ohio's plan revolves around establishing rural health innovation hubs. These hubs are structured as clinically integrated networks, or CINs, alongside rural health regional centers of excellence. The state defines a CIN as a structured alliance among physicians, hospitals, emergency medical services, and community resources. The objective here is straightforward: align clinical, financial, and operational goals across the continuum of care to enhance patient outcomes and control costs.
To actually capitalize these networks, Ohio's budget narrative designates a projected annual allocation of between $90 million and $125 million. This funding is specifically earmarked for a few things: supporting the initial startup costs for these networks, expanding existing infrastructure, and developing shared services across regional providers.
The state has also instituted strict operational requirements for rural hospitals receiving peer group funding under this initiative. Funding is dispersed using a tiered approach to help regions that are in varying phases of development. These networks have to integrate primary care with behavioral health and make use of shared economies of scale. Crucially, as detailed in the state's Rural Hospital Peer Group Funding Opportunity, participating hospitals are strictly mandated to join or form a Rural Healthcare Hub, or CIN, by September 30, 2027. That is a hard condition of the funding.
That brings us to Section 3, Specialized Care and Tech Pilots.
We see a distinct shift in operational protocol when looking at Ohio's approach to rural emergency medical services. The traditional model generally defaults to an emergency department drop-off, but Ohio differentiates its implementation by dedicating $12 to $18 million annually toward an EMS care transformation initiative. This shifts protocols to allow for alternative destination transport, or ADT, and treatment in place, known as TIP. Basically, this allows EMS to either transport patients to appropriate care facilities that aren't emergency departments, or just treat them right on site, which aims to prevent unnecessary and costly emergency care. Additionally, Ohio committed to a precise metric for physical expansion, establishing a minimum of 30 new school-based health centers. The state's project narrative specifies that these centers will be targeted directly at filling coverage gaps in the northwest and southeast rural communities of the state.
Inside those school-based health centers, Ohio is mapping directly to the federal tech innovation mandate. The state is piloting consumer-facing technology designed for early autism spectrum disorder screening. The stated operational goal of this tech pilot is to provide specialized screening close to home. This prevents rural families from having to travel long distances to urban tertiary centers just to get a diagnosis.
Now for Section 4, Workforce Pipeline Execution.
The crucial point anchoring this entire section is a statutory requirement under Public Law 119-21.
According to the authoritative March 2026 post-award FAQ document, any funds used to recruit or retain clinical workforce talent mandate a minimum 5-year rural service commitment. Ohio is required to establish internal controls and reporting mechanisms to ensure this 5-year requirement is met by participating clinicians, and that holds true even if the commitment itself extends beyond the lifespan of the federal funding program.
To manage that pipeline, Ohio structured specific requests for proposals. First, the state issued a single grant with a $10 million cap over the project period for a workforce pipeline coordinator. The focus of this role is strictly on placements in RHT facilities. Concurrently, Ohio issued a separate RFP to centralize community health worker training. This is designed to ensure all CHWs receive consistent, targeted skill building to prepare them for integration right into the state's regional healthcare services.
Finally, Section 5, Budgetary and Administrative Guardrails.
The federal funding here operates on a rigid 5-year timeline. Ohio has to adhere to the schedule beginning in fiscal year 2026 and concluding in fiscal year 2030. Under CMS requirements, the state has to submit annual non-competing continuation applications roughly 60 days before the end of each budget period. This reporting mechanism ensures that CMS has the relevant data on progress and milestone achievement before they release the next tranche of funding.
There is also a strict statutory limitation placed on the use of these funds. The Federal Rural Health Transformation Program caps administrative costs at a maximum of 10% of the total award. This cap applies universally to all direct and indirect administrative expenses. And it doesn't just apply at the state level. It flows down to any subrecipients, contractors, or participating hospitals.
To enforce compliance with those federal expense parameters, Ohio requires all subrecipients to use a standardized categorical budget matrix. As outlined in the state's RFP documents, organizations applying for these funds must strictly delineate between non-administrative and administrative costs across categories like personnel, equipment, and contractual expenses. This ensures the 10% administrative cap is mathematically verifiable before any funds are dispersed.
We'll conclude this explainer by looking at the reality of the timeline. The federal funding window for the Rural Health Transformation Program is finite. It closes in fiscal year 2030. While Ohio has outlined requirements for sustainability plans, a lingering question remains. How will state-level programmatic success, specifically regarding these specialized infrastructure networks and those mandatory 5-year workforce commitments, be sustainably tracked and funded across 73 disparate county networks once the federal dollars stop flowing? Thank you for joining this explainer on Ohio's implementation structure.